Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins Senior Director of Strategic Programs, Michael Friedman, will be speaking about hospital inpatient PPS guidelines. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. To submit a question, please type your question into the Q&A box and click Send. Your questions will be seen by others watching this presentation, so please note, if you do not want your name attached to your question, please check Send anonymously. We will do our best to answer all the questions we receive. Alternatively, you can email us questions and feedback to hopkinsamp@jhmi.edu. Please note this program is being recorded. And now, I would like to welcome Michael Friedman to begin our presentation.
Hi, everybody. I want to thank you so much for joining us. I know it's noon Eastern Standard Time, and with colleagues in out west as well. And I didn't check, but I know we have a groups that are definitely in Hawaii as well. So thank you all for waking up and doing what you can to join. And we hope that you find this impactful today. We have groups joining that are kind of all over the map with their journey to mobility, groups that we've known for a long time and groups that are brand new. So as we go through the presentation, I am going to move pretty quick because I really want to get to the questions and answers. And this will be recorded. You'll have access to the recording. And some of those slides you can just hit pause on and use for reference at your own organization. I also have Kelly Daly with me, who is a director of informatics and is the director of informatics for Johns Hopkins AMP. She's going to let me talk a mile a minute through the slides of the Death by PowerPoint, and then she's going to join us for all types of questions and answers, and we do this a bunch. I will mention this. You see there's a physical therapist by both of our names, and then yes, we both went to business school, which some people think makes us evil. But I want you to know this whole program is completely interprofessional, supported by large numbers of nursing, physicians, informatics. I would typically have Eleni Flanagan present with us as our director of Johns Hopkins AMP Nursing. However, when we dig into the nuts and bolts, which is what we're going to get into today about the EHR, really, Kelly and I are probably the best people to speak to that. And you're going to hear us talk about many of our nursing colleagues, because you're going to hear us talk a lot about the nursing EHR build as well. So I'll go back to this. I'm going to go through a bunch of materials, but at the end of the day, if you want to reference more content we have, much of it complimentary, we have a quick start guide. I would go here. You're going to see me reference slides and publications, etc. And so just go to hopkinsamp.org, look for quick start guide, and that's a great resource for you to continue. So this is what we're going to do today. We're going to talk about why mobility matters, but we're going to do that quick because I'm hoping that everyone on this call already understands that mobility matters. We're going to talk about the Johns Hopkins AMP mobility assessment strategy, and that's key, that your organization has a strategy. We're going to talk about the EHR design and build to include documentation efficiency. Here's the big one, removal of redundant and unnecessary fields. That's going to be pretty custom to your organization, but in many groups, especially those using Epic and Cerner, and a lot of their base content, even though it's changed over time, I think the generalities when we've presented this before are pretty common. We're going to talk about e-workflow opportunities and how they translate to human workflow. And then we do need to talk about how you can use that minimum data set for multiple clinical decisions. And then, like I said, we're going to try to get to answer as many questions as we can. When in doubt, if you don't get your question answered, go ahead and send it to that Hopkins AMP email. So this is the 4 M's. And I would argue mobility mattered before. I would argue that the 4 M's makes a lot of sense beyond age-friendly care. It makes sense for pediatrics. It makes sense for a ton of different groups. So, but we're really going to focus on, and what I love about the 4 M's, and just from a context perspective, I've been involved with 4 M's for a while. I'm actually faculty on the Hospital Association of New York's Action Community. We're very familiar with the IHI's criteria, and we've been to American Geriatric Society, Institute of Health Improvement quite a bit, their conferences. And the concept is that these things come together. But for today, and it's not that I won't talk about some of these, and I'm happy to answer some questions on frailty. I'm not going to go beyond my knowledge point there, but we're really focusing on mobility and how you can leverage this concept that's now required by CMS to really move not just to meet regulation, but let's push forward to really driving towards best practices that can help your organization in a multitude of ways. Right? So big picture. Physical function impacts quality. People want to care for themselves more, and declines in physical function are bad, right? And this is why mobility matters. And just so you know, yes, this is my grandmother at all of 4 foot something. And this was some time ago to let you know this guy is now 6 feet and this guy's 6'5". Okay. She didn't grow anymore. But the whole concept of this is how do we keep people independent as they age? And how do we even know? When my grandmother would go into a hospital, let's say she had pneumonia, then a UTI, and she was independent on a single point cane. And next thing you know, she is up and wakeful 2-3 hours a day. Home care comes in a couple times, but now she's had a decline in function and we don't even know. And these are just things that we do in the hospital, but to give you an idea of just why it matters so much to individuals. At the end of the day, we are really talking about quality of life and patient function. And so this is the CMS guideline. There's, of course, more detail there, but these are the structural measures. And this is the line where you see implement frailty screening and intervention, including cognition and mobility. And we're going to dig into mobility. Okay, today. But the bottom line is before CMS said it mattered, it's always mattered. And it's always mattered because many of your organizations already, even just beyond what I mentioned about patient-centric, you already have some committee or some group talking about each of these things. And we know that this cycle of comorbidity disease stability, as it accelerates with a hospital stay and increased length of stay or a complication, we increase total cost of care. So we've totally always cared about mobility. It's just a little bit louder, and it's always been part of all these measures, right? So again, bottom line, bed rest is bad, and it's associated with all these things that we have initiatives around, and many more. And one of the challenges is, especially patient safety, we live in these silos of policies, of committees. Falls is usually the loudest. These are two sides, right? Safe patient handling. Falls, really risk management driven. Safe regulation, law driven. Pressure injury is a metric reportable. And then delirium and mobility are important clinical components. They are part of standards of care like age-friendly, like the ICU, even in some surgical pathways, but they're not really required like some of these are. And so let's talk about falls for a second, because where we started with age-friendly, really it used to be that fall risk was something we looked at. And I think this is the big thing from our take is fall risk assessment is not mobility. They're not the same things. In fact, many fall risk assessments, and I'm somewhat agnostic on those, they're highly sensitive and poorly specific. And that's why in many hospitals, you see almost everyone has a high fall risk or moderate fall risk. And this is what we see. We see that when patients are actually capable to ambulate, this is a study we did, and they're categorized at a fall risk, they're actually 3 to 4 times less likely to walk, even though they had the ability to walk. And so there's a lot in there, right? There's a lot to unpack in the culture, fear of falls of the patient, fear of falls of the clinician, and what happens when there is a fall and what we do organizationally and how loud it is. And so we need to consider, what about all the patients that because they were a fall risk, we're not optimizing mobility, and that in fact is affecting other systems. And so we also know this, and this is from Eric Hoyer on our team, who directs our innovation side of Johns Hopkins AMP and our research. And we know that injurious fallers will actually spend more of their time at lower levels of mobility. And this makes sense. When you look at the CDC guidelines around mobility, they say, I'm sorry, falls, They say we should be strengthening people, working on coordination, working on balance. So if we're not doing that just to meet a fall metric, we're actually making people worse. And so this is what happens, right? This unintended consequence. If we want zero clinician lift, there's zero fall environment, we reduce this culture mobility. And so we need to work towards this concept of integration. And when we integrate, we literally save time. We save time in the EHR, we save time in education. It makes more sense at the bedside, but things haven't grown up that way necessarily. And the nice thing about age-friendly is it's really working to try to do that. If you just meet the regs, though, you're going to stay in those kind of silos, or you're going to layer it on top of other redundant content that exists. And so we're going to talk a little bit about that. So, that CMS says it's good. I've told you it's good, but guess what? We've known for 125 years that bed rest is bad as mobility good. And so the question is, why aren't we doing a better job in our organizations? And the bottom line is we have a translation issue. And we're going to talk about that a little bit. We're not going to go in extreme detail. We have like full conferences on that. Okay. And what you'll see is this structured approach. This is the Translating Research into Practice model, TRIP. It's a quality improvement model by Pronovost that we use. The Armstrong Institute of Patient Safety at Johns Hopkins uses, and we use it as our foundation at Johns Hopkins AM. And this is our 8-step framework. And I'm not going to talk about all 8 steps today. This is part of the quick start guide. So definitely, please, it's a quick read. I'm not trying to assign homework. This would be one of them. And these are the steps that you really follow through to get a culture of mobility to stick within your organization and not be the little project that we tried. There we go. And so when we've driven that project, and these are all publications, when we've used that quality improvement approach, we've seen mobility improve. This is the big one, and we'll come back to that. We've seen that when nursing mobility assessment alone occurs, when all we do is do it systematically, more patients achieve mobility goals, or more patients move further. We also better target rehabilitation to patients of greatest impairment. We're able to repeat this in both academic medical centers and community hospitals. And I think many of you know that our tools and this isn't something that just we created at Johns Hopkins. They've been disseminated globally. Number of organizations, translations exist. And it's actually in both the IHI and AGS, American Geriatric Society guides for measures. So this is what we're going to focus on today. The blues are things to think about. The red is what we're going to focus on. And the bottom line is this. What the CMS age-friendly considerations really are pointing towards and allowing an avenue for is adoption of a systematic measurement approach. And not all, but many organizations we go to, that's lacking. In fact, there's nothing, or it's just done by one discipline and not done consistently, or it's done by one service, maybe orthopedics, or it's only done by physical therapy. And so we need to get to a place where we're measuring mobility and it's part of the flow, no different than falls, nutrition status, bowel and bladder, and it's part of the care plan. And then we have to feed back data on it, key performance indicators to see, are we doing well or not? So we've talked about age-friendly, and this is what's important. Age-friendly is totally one of the things people care about. However, all these other things are things that organizations care about. And the bottom line is your approach to mobility can touch them all. So the aim here is 7 birds with 1 stone. And so as you're thinking through what we're doing for mobility for age-friendly, we should be saying, hey, totally works for lumbar spine surgical pathways. This totally works for things that we're trying to do around reduction to post-acute care utilization. So there are opportunities to leverage all those elements. And you can also use these same tools for other clinical decisions that I'll go through later. So this, at the end of the day, is what we're recommending that you implement. And it is the Johns Hopkins Mobility Goal Calculator. And it serves a basic function, much like anything else. One, you do an assessment of the patient. You would do that for many things. There's a normal value or goal for that patient. There is an actual recorded performance. And now if you can compare a performance to a target, you now have variance and either immediate action or establishing a plan. This is no different than blood pressure, right? There's a normal value. There's an assessment. It's compared to what that normal value is. Lab values, again, bowel, bladder, nutrition, cognition. These end terms are all the same, but we don't necessarily have that common language for mobility. And then we're going to talk a little bit about these scores here, which are the AMPAC mobility score, and these, which are the JHHLM, and how they come together in actual work. So let's talk about strategy for a second. These were the strategies that we advocate for and have put in place. And these are our guiding principles, and we know that they're distinct sacrifices. Okay? One, it has to be practical and feasible. Right now, when we implement this program, we can see organizations, if designed the right way within the EHR, get north of 90% compliance with assessment within 3 months. I mean, that's pretty high to be able to do that. One, it needs to be generalizable across populations. We don't necessarily want a specific measure for stroke and a specific measure for total joints and a specific measure for general medicine. Not that you can't have those, you totally can as secondary measures, but as your main metric, okay, it would be like having a different measure for CLABSI or a different measure or approach for blood pressure for all different populations. It has to be across interdisciplinary or interprofessional. It has to work, be a common language across teams, physician, providers, nursing, therapists, case management. It needs to be meaningful. We have to reduce documentation burden. It's got to be click for click reduction, but at least click neutral. We want to meet regulatory needs at the exact same time. And then these are things we want: meaningful across settings, drive clinical decisions, not just be another number we're collecting, small training burden, right? And we also want it to work for as many clinical initiatives as possible. And these are some of the sacrifices: a level of precision. It might not be setting specific. It's not going to be specific to a discipline. And so to start with, we have this concept of capacity. This is the expectation of what we think a patient can do, not what they actually do. And this is the AMPAC. And so we use the AMPAC. There's a ton of science behind it. And what this does is essentially, if you are completely independent, you would need no help on any of these things. And I don't need to actually see it. It's what I think as a clinician, and I'll show you in a second. But whether you're a therapist or nurse, and it's just based on the other information you know, we know that that has strong psychometrics and it's reliable and valid. So you can ask me, how many of our nurses take patients actually up the stairs? It's close to zero. How many of our therapists do? A large number of them. And we find the scoring of this question very close and psychometrically positive. And then to the frequency with which this is recorded, this is an assessment. So nursing would do this each shift, usually at the beginning of shift. And PT/OT does this each visit. And then this is performance, or the observation. Very simple scale, 1 through 8, but these numbers are actually meaningful. 250 feet is a marker for able to ambulate in the community. 25 feet is in home. 6 is in room. 5 and below is preambulatory. 2 is in bed. Those are all major milestones as we think about discharge planning and care planning for a patient. And again, nursing, this is an observation, so it does not need to be completed by the nurse, but a member of the team. Again, we've been to a lot of different hospitals and a lot of different people call different people different things. So that's some of the list, okay? We do want it later in the shift. We don't want this recorded right away when someone's laying in bed, especially day shift. And then PT/OT each visit. And then now you can see this is from the American Geriatric Society publication on the need for assessment. These are our two tools. And you can see the key about these two tools is they are the ones that have been used interprofessionally by different organizations, used in the hospital specifically. And then we'll dig a little bit deeper into how many decisions they can help drive for just one entry of a number. This is the study on psychometrics of the tool. And it really just at the end of the day says there's strong agreement between nursing and PTs on utilization of the tools. We've also seen that these tools have great psychometrics as well for use in the ICU. And what you're going to get to here is development of that concept. At the end of the day, and this is what we're going to talk about in the EHR, and this is what we're going to talk about as age-friendly for that concept of assessment and intervention, right? Those are the two concepts. So the concept is every day, every patient has a mobility goal. Okay, so you're doing an assessment that's driving that. You're also doing an assessment on the ADL side that's driving some of that. And that mobility goal and the act of achieving that mobility goal is the intervention. And you're able to report on the amount of time or the variance at either an individual patient level or to scale of the ability to achieve that goal. And these are a couple publications on development of the tool itself, but then generally this concept of goal-directed mobility of medical inpatients, even beyond the Johns Hopkins AMP tool. And so this concept of setting a mobility goal is the key, and not necessarily one set by ourselves. When we set ones by ourselves, the challenge when it's not calculated or based on an assessment is we build all our own barriers into it and we artificially set goals low. And we'll talk about that back to falls, right, in a second, where patients can totally walk, but they're not walking. So remember, every day, every patient has a goal and a plan. And so let's talk about falls. This is another study we did where we did that. We looked at those patients who were ambulatory and had that moderate and high fall risk. And the minute we put the goal calculator along with that fall risk information, we had 97% ambulate in the moderate or achieve their goal, and 93 in the high category. And we didn't have any injuries in any of these situations. So the bottom line is that this strategy of an individualized capability may be an effective strategy for overcoming those barriers. And think about barriers beyond fall risk, right? There are other ones as well. Lines, tubes, and drains. Medication management and understanding if there are things we need to do to change medication. Pain. There are a ton of things and barriers that we can better understand if we have a better idea of what the patient's capability is versus their performance. Okay? And so then this next study, I talked about click reduction, and we're talking about the EHR. There are questions, right? Whether it's the Morse or the JFRAT or the Heinrich falls, or it's the Braden pressure injury scale. We know that scores on the AMPAC can actually be automated to click answers there, literally reducing one click at a time, reducing click burden. So that's the other thing we want to look at. What's the least amount of assessments we can do for the least amount of clicks as we think through how we're developing and meeting designs in the EHR. And I know we're talking about this nuts and bolts stuff about the EHR, but what we find is that's the real challenge, is people really trying to get their program to stick, use data from their system, and getting people just to do the assessments consistently. And to do that, we need the workflows to really be as clean as possible. And then another opportunity, and this is a lot, please don't look at it too much, but the bottom line is this is another study we did that looked at that same AMPAC score. And with age, what's the likelihood of post-acute placement versus going home? And so that same number we can use in care planning with case management or interprofessionals. So now, and I think I'm not here, I can look, I don't. We also know that that number helps target rehabilitation. It was early on. So now you're talking about 4 or 5. We also know it can be tied to VTE risk assessment. There's a number of things that we're using one number for multiple clinical decisions, which is super important, besides just the basics of meeting age-friendly criteria for CMS. So on top of that, we have a couple more tools. Remember that AMPAC score and that mobility? Well, these are the ADLs tied to them that can be part of just the daily life of the patient. And these are a big part of the, when you look at frailty assessments, all of them also have an activities of daily living component for the most part. So this is another thing to think through. We call this exercise with purpose. And what we find from our nursing colleagues a lot is this and giving permission that these patients can do it. And it fits more into the workflow and day of the clinical bedside nurse and nursing versus some of the walk 500 feet type concepts. And then also the use of safe patient handling equipment and actually helping drive that decision. Many of the people that you need significant safe patient handling equipment on are for longer lengths of stay. So the ability maybe at 4 or 5 p.m. the night before to recognize what you might need for evening shift or the next day to facilitate mobility for your toughest mobilizing patients. So let's get to the EHR design, and I'm going to try to move quick through this, okay? And so this is the minimum data set, 6 clicks, JHLM calculated goal, and JHLM observed. For Epic and Cerner users, I'm going to tell you there are a ton of examples in your, whether it's the user web or the library, there are plenty of organizations using it that you can look at. Some of them, we can't necessarily say if they built it exactly like we would. So we're going to share with you some generalized screenshots using the verbiage that we would use, okay? We talked about removing redundant stuff, aligning items, and then the activity order, and there are a couple other things in here. So number one, build the nursing flow sheet in that systematic language. I showed you the AMPAC, the 1 through 4, and then you can see here down at the bottom, here's the goal calculated. So it's an automatic calculation. And then here you put the JHLM observed. This is the calculation right here. And then this is that highest level of mobility performed. And then the ADL build is similar. And then where you position these things in your flow sheets can alternate. We generally say build the activity first, followed by the mobility. And just so we're clear, this is actually an error. I apologize. There is no 0 score. That should not be there. That's an error. So then you can use the concept of work list or tasking, and the functions are different in different groups. There are ways to develop tasking, but the concept of, and we recommend 5A, 5P, it can be different, but this is what most organizations, it wasn't even us who did this first, but the concept of establishing a time near the end of shift where they would have gathered that JHLM and make sure it's taxed so that it's collected. And that is a best practice for people assuring that they're doing that observed documentation. We call this untangle the spaghetti. And we do this with many organizations, and we would suggest that you do it yourselves, which is go through your existing activities of daily living. The pick list are probably extreme. And what are the things that you can start to get rid of, right? Dependent level, number of staff to assist. The inter-rater reliability on this term is big time questionable. How often is it even filled out? You could check. Current level of assistance would be covered by the AMPAC, right? So there's all these different things that you'll find that you can totally get rid of that really don't drive value. But that's something that you as an organization need to, one, go through, but two, I would evaluate how much is it actually being completed, what's the inter-rater reliability on those responses, and is it driving clinical decisions? Okay? And then we move to patient list type concepts where you can, run rounds, whether it be interdisciplinary, clinical rounds, different groups have banners. Now that the numbers are in the system, you can do a ton of things. We could go here looking for patients at high levels that maybe don't need rehabilitation. We could look here for a patient that, hey, maybe they have a post-acute care, but maybe they could totally go home instead of SNF. And then we can also see the goals and allocate our resources for what their calculated goal is for the day and who are the patients we're most concerned of. This is the activity order, and the biggest thing we see when we go to most organizations is they don't have this concept of as tolerated versus bed rest with as tolerated as the default. They may have 30 different terms: out of bed TID, out of bed with bathroom privileges. And then they actually have other things around head of bed or braces. We usually include head of bed, and we recommend head of bed in some of the ortho, like range of motion and weight bearing, since they're more common. But then you might have other ones like cardiac restrictions or things like that. You can totally implement those as separate orders as part of the order set, as line item orders. And these are examples of the different types of braces, et cetera. And then this is from a colleague of ours, Our Lady of the Lake in Louisiana, and they actually have built something around physician and engagement. And so at physician admission, as they kind of take in all the elements of that admission, they also try to understand their baseline highest level of mobility. And that gets physicians just speaking the language, and then also another piece of knowledge as we move forward towards another piece of knowledge as we start setting goals and moving forward. With that in mind, and just having a number, think about that. Having a patient target and performance, we can do basic things in workflow integration, right? Signs on walls, whiteboards, door sleeves, cards, conversation with the patient. We showed you patient lists, handoffs, charge nurse handoffs, interprofessional, clinical rounds. You can do all types of wild things with EHR optimization. You can look at alerts and really move up the ladder. And this is all a level of complexity, but you can't get here without that systematic common language of mobility. And then with that in mind, you know, now that we have this measure, and I want you to think about things like falls, length of stay, pressure injury, there's always a key performance indicator associated with them that tells you, am I doing well or not? And where do I target my quality improvement? And in the absence of a data feedback loop, how do you know if you're doing well or not? And I tell organizations that say, we mobilize patients, great. I don't know if I should believe them or not. Until you measure it, you have no idea. Until you measure it, we can't drive performance. And we're big believers of using data to drive culture. And that's ultimately what we're after. And if you have a key performance indicator, think about falls. When that metric turns just a little bit up on a given unit, what happens to priorities, dashboards, strategic plans? I mean, there's a lot of volume. Do we even know on the weekend if patients moved or didn't move? Do we even know how well they're doing? I would argue with total joints we do, where we have distinct milestones in most organizations. And when you don't hit your milestone post-op day 0 or post-op day 1, it's actually on a dashboard. But what about a general medicine patient? And so the concept is really to push that, and especially in the age-friendly world, to understand that for our patients that meet that criteria. You're never going to hear us say stop at age-friendly. We're going to say this should be true of all patients in the house. So the first metric back, the first KPI, and these are better days, they weren't always this way, but is documentation compliance, right? If we don't even have an impact done, we don't have a goal for the patient, and you have program failure. If you're not recording performance, we have program failure. So just alone, and the work we said is all we do is assess. We're not going to teach safe patient handling techniques. We're not going to work on patient engagement and overcoming refusals. We're not going to optimize our order sets. All that stuff we need to do. I want to tell you, we need to do all that stuff. But to even move the needle to scale, if all we do is put an assessment and goal in place, we're going to start moving the needle. Okay? Then those other things we just talked about, instead of investing $1 and getting 20 cents return, hopefully you're investing $1 or an hour of time, right? And you're getting threefold the return. And I think we talked about this publication earlier about just documentation compliance rates and how important it is. And so then we move to KPI 2, which is, are we actually mobilizing patients? And you can see, I always use this example, what happened around here, that's COVID, okay? So this was patients who could walk, and this is probably not the best example, but we had a lot of issues with, at least at Johns Hopkins, could patients actually leave the room, right? But you see this big number of patient days where a 6 is patients walking in the room, where we want them to have the ability to walk further. And now you have the information to start looking at goal achievement. Are people moving as far as their capacity? And that's ultimately what we're after, right? We want to optimize patients' function so they can reduce all that stuff in the bed rest is bad slide. This is a KPI 3 where we actually target rehabilitation. And our aim is to try to get rehabilitation to our most impaired folks, to reduce discharge to SNF, to get people home faster, but not necessarily to see people that are already walking down the hallway to go get a sandwich. And so this is an opportunity to put some numbers behind that to better target resources, no different than we target MRI, blood products, et cetera, for appropriate utilization and other consult teams beyond rehab. And this is, I mentioned total joints, but this is how you can get to specific populations. Now that you have goals, we can literally look at post-op day 2 at a certain facility for a given surgery and how well are they achieving goals or not achieving goals, so you can target your quality improvement. And you can do this for a number of other things, right? Now that you're systematically collecting data, we can slice and dice a lot of ways to tell us the story and improve our targeted quality improvement. We don't have the ability with the resources hospitals and health systems have to have a shotgun approach. We need to act with a lot more precision if we want to make improvement. And so at the end of the day, right, mobility matters. CMS guidelines, I'm so glad that it's allowed enough, and groups like the IHI and AHA and College of Surgeons have supported it so that it became a structural quality measure. But it's really mattered before this. And my hope is that organizations can use this move to CMS and this need to build systematic measures and reports in the EHR to their favor to connect the dots to other things they should be doing and really develop an optimal solution to make this part of care plans. So I always leave, not just me, Kelly's on the team, all of us, we always feel like we do these webinars and you leave like these ideas. And we have a thing, we always say, what do I do on Tuesday? Okay, so it's Tuesday, so I'm like giving you a week here. So 1, you're gonna review that JH-AMP Quick Start Guide. That's number 1, okay? 2, what are other clinical initiatives beyond age-friendly that kind of align already? That this is really, again, 7 birds, 1 stone. You're gonna look at your current EHR and back to that untangle spaghetti concept. Okay, and you're going to look at the minimum data set for AMP, and you're going to say, hey, what can we take out that this fills? You're going to start to talk and think about the EHR workflows, things like tasking, patient list, et cetera. And you need to consider your reporting needs. And most organizations have business intelligence, whether it be BW reports, or ClickView or Tableau, but reports can be generated out of all those softwares. And so just back again as a resource, and then we'll open up for Q&A, but here's the resource guide again. And then big picture, if you're really going down the road, not really going down the road, we do have a foundations course you can take. That's kind of the easiest way to dip your toe in the water, your organization's toe in the water. But went backwards. But the bigger thing we do is every year we do have our big conference that organizations come to that are both just starting out, and you can attend both virtually or in person. So did want to put that up there, and that's on the website. So with that in mind, I'm going to keep sharing, but I am going to ask you all to, let me see what I got here in the Q&A. We'll kind of open it up. And I'm going to ask you all to pile into the Q&A. I only see 1 question right now. I'm going to ask Kelly to hop on screen, and we'll go from there. Okay? And so don't be shy. Get those questions in there. I'm happy to go back to slides as we need them. Happy to talk detail. So this is a long one from Melissa. So bear with me, everyone. But Alyssa gave me some good detail, which is important. We have implemented a hospital-wide mobility program utilizing our framework. The difficulty we're having is timing the population of the nursing mobility goal. For example, our mobility goal for the day is calculated based on the shift before. The goal is usually written out on the patient's whiteboard or note of the patient's door. So this is about workflows, okay? And the goal is calculated. Do you have a suggestion on the timing? Oh, yeah, so I do have a suggestion on the timing. One, AMPAC should be done at the beginning of shift because that's really similar. And I wish I had my nursing colleagues here. So I am generating my Eleni Flanagan, or Stacy Daniel-Check, who are our nurse experts here. And Kelly can attest to this, but we understand that nursing assessment really, that happens when you come on shift. So aligning the mobility assessment with other assessments is important. Now, the important component about the AMPAC is you should take everything you already know into account when you fill out the AMPAC. So you're right. The previous shift's AMPAC and the previous JHHLM should matter in that AMPAC that they're doing. But if they do that AMPAC, think right away, right? 7A, 7P. So the day shift does it at 7A based on what they know from the 2 shifts prior. That's valuable, okay, for them to know. I appreciate even on a new admission that sometimes can be a little bit more challenging to gather what you know, but it's okay that AMPAC change over the day from the first shift as you learn more about the patient. And so that would be the timing for it. And then usually the workflow or the human workflow element we do is at near or at shift change. So the clerks or the people who could be assistants or techs are helping to populate those whiteboards at those times with those goals. I hope that's helpful. I don't know that that's the only way you need to do it, but that's generally the way we recommend for organization. And we also understand organizations might have different workflows that they need to adapt that makes more sense for them. Kelly, that's a more workflow-y thing. Anything to add there?
I would just say that does make absolute sense. But if the question is really drilling down into like the details of the EHR build and what sort of time window you're using and that sort of thing, Michael, where did you want them to send questions? Because I'd be happy to entertain that by email or even a short discussion.
I think if there's more detail than we get to, please send all questions to hopkinsamp@jhmi.edu. You can go to our website, it's there, and just send the detailed questions. And Kelly's, believe me, if you want detail, Kelly will give you good detail that's really valuable and she does this in the all time in very concise emails. So it's fantastic. Okay, I'm going to move on here. This is from Peter. You correlate AMPAC score with ADL, but without specifying levels of assistance. Can you clarify how this relates to need for fall avoidance? So levels of assistance, you totally can put levels of assistance on the JHHLM, but the AMPAC itself tells you what the levels of assistance are. So when you do the AMPAC, you use that along with the JHHLM and the ADL to see what the assistance. If you notice the ADLs are not about the ADLs themselves, but it's really the position they're in. So are they able to stand? Are they able to do those elements? And so that really comes from the AMPAC itself, which already has total, a lot, a little, or no help tied to it. And so that would be our thing there. What we find the biggest thing around fall avoidances is, are people actually using equipment that would be appropriate for those patients? That's really the bigger thing. Let's keep going here. This is from Brittany. We are working on implementation of AMP. I haven't been able to find the details on how the AMPAC can populate fall risk assessment tool and how that build would be designed. It would be nice to incorporate this into our brain pressure. I'm wondering if it's simply that they have mobility deficits. Brittany, what I would suggest you do, and I don't know that we have this in our implementation guide yet, but I would read that publication specifically, and it tells you the rule set. And it tells you at what line a certain AMPAC score and how it answers the Braden or the Morse or the JFRAT, I believe. And you have to double check me on the Morse, because there was one of them, one of the fall risk scores didn't exactly come across as well. And then you would see where you draw the line on, if the AMPAC is this, it equals this score in your mobility. I will tell you this, the AMPAC is much more precise and goes pretty far down in patient function, where most fall risk scores, like the minute you're not really highly mobile, you're a fall risk. And so it's pretty easy to automate that, Brittany. But I would, why don't you read that publication in a little bit more detail? And we can follow up here, but we don't have a specific guide for you right now. Good question, Brittany. This is from Chelsea. We've been using the AMPAC at our hospital system for quite some time, both nursing and therapy. We've always had discrepancies in what nursing document versus therapy document. They're a 24 when they were really a 16. So I'm assuming this comes from therapy. So first of all, I'm going to argue, one, we've been a lot of places, and we don't always see that therapy gets it necessarily right compared to nursing. So I'll start there. But there totally can be discrepancies because of time, but also because of education and follow through. And so I don't know if that's a new nurse or this, but at scale, I can tell you that when we do this, there are differences, but those differences are not dramatic and they're within the error of the tool. I appreciate the difference between a 24 and a 16 would change a clinical decision. We're going to come back to that in a second. Do I have suggestions on how to educate staff? Okay, 1000%. And here's the key. We can do all the e-learning in the world. I can show you all the PowerPoint presentations and case examples. What's really going to matter is in those instances just in time that we have conversations about those metrics and improve literally patient by patient, resource by resource. I don't know if you're set up with just-in-time resources on the units. We tend to believe that nursing is fully capable to educate and train nursing alone and does not need therapy to train them on the AMPAC and HLM. So I would not have rehabilitation specifically. They should totally be a resource. And there should be an open conversation about why someone received what score and what they saw where and how they got at it. And so really it's just in time and it's reinforcement. And then it's getting back to those individual groups and common issues. So a common one is people still looking at observation versus what they think the patient can do. And that's the biggest one we kind of still see. And also, if you have contractors, people who shift floors, new hires, to make sure you have a sustainable system to make sure they're brought up to speed just like everyone else. Chelsea, it's a common question, and you're never done. I would argue that fall risk assessment and other tools also, they're regularly concerned about how well are people doing falls, how well are people doing Braden. And so it takes constant effort and stick-to-itiveness. Okay, we got the anonymous attendee. I'm just kidding. It's all okay for you to send me the anonymous attendee. We are in the beginning of the process of putting together our education for mobility advocates and frontline staff. So just for those of you who don't specifically use AMP, we use the term mobility advocates. Really, they're just-in-time unit-based resources. And often they kind of cross over other initiatives, right? Like falls, pressure injury, VTE. That way you can have a foot in multiple camps, okay? When putting together the education, how long does the education take for mobility advocates and the frontline staff? So these are good questions. And so let me be clear on education. There are not standards out there, and I'm talking beyond AMP, about how many hours of education you need to assure that someone gets it. And so at a minimum, we know what's pragmatic. And what's pragmatic is this, and this is what we do and other organizations that we work with do. They do some sort of e-learning that is several modules on the specific elements that is always available to frontline staff. But the key there is that's just an entree. Then as part of that, and Kelly could speak to this a little bit, is where do they actually do this in their EHR? And they're used to doing that as part of a change control or anytime something new happens. Then the mobility advocates, our aim is to have 4 hours of directed education in a train the trainer concept that puts them in the position to be able to be just-in-time resources. And then it's really, are those mobility advocates voluntold or are they engaged, right? Are there incentives for them to, why are they involved? Or are we just sending them to a course for 4 hours? And if you have turnover of those advocates or high turnover, you know that you have less people that are engaged and you're actually wasting time on the education. So while that's important, it's about introduction, selecting the right people, and then really the key for the advocates is the ongoing monthly conversation with, leadership and the support from leadership, nurse managers and directors. And at the front lines, what are they doing that's really specific to the action or the issues of their unit? And so I appreciate you're asking a very concrete question, which hopefully gave you a concrete answer, but I believe our emphasis is more on that just-in-time element, and then building it into things like, if you do them, skills days, competencies, and all those other areas, so it's intertwined. I'm going to hand it to Kelly for a second, because there are some specifics around EHR education and kind of making sure people do that the right way. Kel?
And you're speaking about the navigators themselves?
I'm saying when someone gets, a frontline staff member gets the welcome to AMP, here's the JHLM, here's the AMPAC, here's the goal calculator, we can show them that, but in their own organization, there's something specific to where do they actually document and what is their actual workflow.
Oh, sure. And as those things change, I mean, you have your normal orientation for new staff, but as these things change in the EHR, generally there's a blast or a blog that comes out and describes how to use those. I don't know if that's what you're getting at.
Well, I think that each organization needs to spend enough time on where and how does it actually work at their organization, aside from here's the tool, where is it actually,
Right, and how to really work it into your human workflows.
I'm going to be being mindful of time, trying to move us along. We're looking to put JHAMP, but they don't have enough safe patient handling. What do we recommend? So I think this is it. And just we've been to organizations around the world. I don't know you all, but I'm assuming you're all US-based organizations, and I feel comfortable saying that in the US, in Europe, in some of the Middle East, the amount of equipment, clinical personnel, expertise of clinical personnel is far more than many other places in the world. We've also been to organizations in the US that have different nurse ratios, although they tend to be closer. The techs are all over the place. Vacancies are a different thing. Therapy staff is all over the place. And the bottom line is, it doesn't matter what safe patient handling equipment you have. The bottom line is you can make tomorrow better than yesterday, having a measurement system, a data feedback system, and making mobility louder and part of workflows, okay? It doesn't mean that we shouldn't still be doing what you're suggesting. We 1,000%, as I'll tell you, every hospital we go to, when we look at them, they tend to have not enough stand pivot devices, okay? And should you be doing a physical environment assessment? 1,000%. In fact, in 2 weeks, I'm going to speak with a bunch of architecture firms on this concept. But I want to be clear that often we get caught on resources, personnel and equipment, which are tough, right? Budgets, priorities, no one wants to spend money. But I would argue having a system will then allow you on whatever investment happens next to have a greater investment. And number two, by implementing a system, you have demonstrated equity in your team that you can get from point A to point B and show results. with what you have. And that's why it's worth investing in you over the other constraints and priorities. So I hope that gives you some ideas. And again, I'm not walking away from what you mentioned, but I'm also saying, don't say we can't go just because we can't buy equipment. Go, get after it, okay? And in fact, that data will help demonstrate opportunities that the organization's missing, because you could say, if we had this equipment, we could have gotten these patients, right? These neuro patients, we think they could have achieved goals and they're more likely to go home. So there's an opportunity to actually use that data to your advantage to justify. Thank you for that question. It's an important question. Laura, and I have to be watching this, unlike my own webinars, this one actually shuts off at 1. So if I don't get your question, please shoot it by email. I think this holds on to the questions, but just in case, please shoot it by email. When we refer to KPI 2, daily goal achievement, you capture what's in the EMR using JHLM documentation 3 times in the period. We added a mobility achieved. I have to admit, Laura, I'm having a tough time with, I'm just not following the way you wrote it. I'm sure it's probably much clearer than I'm reading it. I'll just say this. When we capture KPI 2, we look at 2 documentations a day, midnight to midnight. We capture the highest level, okay, of mobility. It doesn't matter if they had 3 scores. We actually pick the highest one they scored. And so we're big believers in the KPI. We grade on a curve, okay? There's a lot of different ways we do that, but we grade on a curve. And so what we found is when we do that as a KPI, the overall mobility of the patient is higher, even if it's just recorded that one time. I hope that answered it, but if I didn't, Laura, send us an email, okay? David Cole, I feel like, David, we know you. I feel like I've seen I feel like you've sent us stuff before. What is your recommendation for getting senior leadership convinced that this program is valuable to the organization so they're willing to prioritize it? Great question, David. We actually, there's a number of things out there on financial benefit. We actually are doing one again, but at the end of the day, it's this. It's that you take that bed rest is bad slide and you take each one of those, and there's evidence supporting the value of mobility to reduction in each of those. The challenge becomes is they're going to ask you for actual dollars. And the question becomes this. They don't necessarily ask for actual dollars on reducing falls, right? And so we got to get out of that conversation to, we know mobility improves this collection of outcomes. And then individually, what are the savings on those outcomes or savings opportunities? David, I would expect more from us. We do a presentation on getting to yes at our conferences. But if you're looking for a specific calculator on length of stay, the reality is organizations are doing so much on length of stay that that's a hard thing to customize. That said, if you go to our website, we do have a length of stay calculator that's based on our publications that you can estimate. And again, that depends on what state you're in, but in most states, the length of stay is a financial. I got 2 minutes here. I'm working hard. Good question on this one. And I'm not going to get into brands, but stand pivot devices, et cetera. The bottom line is this. If someone is actively moving, actively, I don't care if it's just a little active, but actively, that means not a verticalization bed. There's a place for them. Not a chair to press yourself to a seated position, but if they are actively working and it's not dependent, then they're a 3 or a 4 on JHLM. If it's dependent, they're a 2, if it's total help. And I appreciate different equipment, you can set different ways, right? But if it's a dependent, it's a 2, bottom line. What do I recommend as a goal for KPIs 1, 2? KPI 1, you want to be north of 90% compliance. KPI 2, I really look at baseline and improvements on goal achievement. That said, and we don't have benchmarks on this, but just organizations we go to, I tend to like to see in the 6 and 7 and 8 categories, north of 75% goal achievement. When you get there, I think that's something that we see many organizations get to. In the 3 through 5s, I have some concerns about the number of 2s. And so one thing, and Kelly and I are working on this, is looking at total 2s. Numbers of patients are in bed rest, and that'll probably be a new KPI for us in the future, is as an organization, how many patient days were patients in bed rest? Okay, thank you, Laura. I'm glad I answered your question. So it seems to me we got to a lot. I think I'm going to shut off here soon. So I want to thank you guys so much. Hopefully this gets you down the road. We are going to probably do something in about a month, like probably a more Q&A. This will be available if you have other people that want to look at it. They can, and you should get a follow-up email with resources, etc. I want to thank you all so much for your time. I want to thank Kelly, and please, I appreciate some people might not have the right people on to ask Kelly questions. If those people have follow-up questions, go ahead and shoot that email over, and Kelly's happy to talk with groups, especially in the informatics or EHR design groups. Anyway, thank you all and have a lovely afternoon or into the morning. Bye-bye.